What's the opportunity here for improvement in England in managing these high-risk conditions? How well are we doing currently? So if we take high blood pressure, currently we're picking up about 60% of people with hypertension. And when we pick them up and they go on our QOF register, we're treating about 60% of them to the 140/90 target. I find that so striking. When I was at medical school, 30-odd years ago, I was taught the rule of halves, and we haven't progressed a great deal in that time, despite having one of the best general practice systems in the world. With atrial fibrillation, although we know how effective anticoagulation is for our patients, if you take the people on my register, they've got AF, it's recorded, when they go into hospital and have their stroke, only 1/3 of those people will have been anticoagulated, despite the benefits that the treatment can offer. And with high cholesterol, there's debate about what level you should offer statins, of course, and of course, behavior change is the most important thing to focus on here. But only probably less than half of people who've got a 10-year CVD risk above 20%, less than half are getting statins. So clearly a lot of potential to improve outcomes for our patients by improving secondary prevention. A NICE's model, for example, if we take atrial fibrillation again, if everybody who was eligible for anticoagulants in AF got their anticoagulants, there'd be 10,000 fewer strokes a year. That's a very large number. And clearly not all of those people would be appropriate, but I suspect a majority would. But even if we only reached 50% of those people, we'd still be saving 5,000 strokes a year. That's 25 strokes in every CCG, so not an inconsiderable gain for our patients. But that's all very well. And it's really important, as we all do in this room, to think about the real world that we live in general practice. We're all very much overworked, and we have zero capacity to be doing extra stuff. So pulse taking, blood pressure checking, counselling about statins might sound very easy, and we know it's important, but it's often trumped by other priorities that the patients bring to us. Patients often have multiple priorities of their own that they bring to consultations that don't leave time to talk about anything else. So I don't think we're going to improve care and outcomes by working harder. That's clearly not an option for any of us. I think it's only going to be achieved by doing things quite differently. In other words, by making the system work better for us and for our patients.